So good morning, everyone, and welcome to this morning's webinar. I, as always, like to start by thanking the Venous and Lymphatic University for this incredible opportunity for us to meet and talk about all of these important topics. And I definitely want to thank Victor and Victor Canada and Dr. Lowell Kapnick for trusting me to lead these webinars, and my partner in crime, Rebeca Riachi, vascular surgeon from San Luis Potosi in Mexico, for helping me so that we can keep these webinars going and these discussions open. So today we're going to talk about it's a very important but topic that we don't talk about enough, which is pelvic venous disorders. And we have three amazing physicians from around the world, and they're going to be walking us through this condition, what it is, why is it underdiagnosed, how do we find it, how do we make a diagnosis, and then finally, how do we treat it? So thank you guys for being here, and let's get started. So I'll give it to you, Rebecca, to introduce our first speaker.
Thank you so much, Lina, for being my partner in this one, and thank you for the invitation. Of course, thank you to the VLU for this kind of topics that we are going to talk about it. I'm going to present the first speaker, that she is a really good friend, and besides that, she's a great and amazing vascular surgeon. She is a Dr. Vanessa Rubio. She's from Mexico, and she lives in Guadalajara. So please, Vanessa, if you want to share your talk, please.
Good morning. Thank you for the opportunity to present in this talk with such great speakers. I'm going to talk about pelvic venous disease and the importance of its recognition. Pelvic venous disease is frequently an ignored pathology. 40% of women suffer from chronic pelvic pain, and about 30% of this is related to venous disease. Sometimes it's even more in imaging, up to 47%. However, it's very rare in postmenopausal women. About 30% of women will present with this pathology. And historically, it was thought that women had some kind of a relation with their uterus and their psychological status. And they were meant or said to be psychologically unstable. And sometimes this pelvic congestion syndrome would be related to a psychosomatic stress disease. Fortunately, this was changing, evolving in 1978 to the recognition of some symptoms relating to a vascular disease. However, sometimes it was even mentioned that taking away the women's pain might lead them to psychosis and suicide. Fortunately, this has been evolving, and now we have to be conscious of the possibility that women might have these disease hidden underneath. It's related to depression in up to 50% of women that presented, anxiety, and some somatic complaints. It has an impact on sex life because it has to do with urinary pain, pain during menstrual cycle, and dyspareunia or postcoital pain that will even last for 2 days after sexual intercourse. The clinical presentation relates to chronic pelvic pain, varicosities in the gonadal area, in the buttocks, in the upper thighs, pelvic congestion syndrome, hemorrhoids, these atypical veins, and a large percentage of women are underdiagnosed. There's 3 types of presentation. The first type relates reflux, and it has to do with valve pathology. The second type has to do with stenosis or obstruction of the left renal vein or the iliacs, and the third cause has to do with a local pelvic compression. So we can see some examples of the ovarian vein reflux and the varicosities in the pelvic area that might produce the symptoms. The second type relates to stenosis or obstruction, and in here we can find post-thrombotic etiology or an external compression, such as the left iliac vein compression syndrome, or the nutcracker syndrome, where we can find a very dilated gonadal vein with pelvic varicosities. The third cause has to do with a local cause or, for example, a pelvic tumor, which might compress the pelvic veins and promote collateral flow. So the AVLS proposed a classification, the SVP classification, which helps us a lot with the clinical presentation. It provides 4 anatomic zones to explain the symptoms, the signs, and the physiopathology. The left renal vein is the first zone. The second zone has to do with the gonadal and internal iliac veins and the pelvic venous plexuses. And the third zone has to do with pelvic origin, extra-pelvic vein in the genital area. The fourth zone has to do with the lower extremity veins. And it's the SVP classification because it has to do with the symptoms, varicose veins, and physiopathology, which might include the hemodynamics for obstruction or reflux, or the etiology, thrombotic and non-thrombotic or congenital. So the symptoms, we can have symptoms of renal origin, or we can have chronic pelvic pain of the pathology, or extra-pelvic symptoms. The patients might have less than 10% of patients with varicose veins might have symptoms. And on this percentage of the population, we have to focus our study, because it's only symptomatic patients, the ones that will warrant to have a benefit from treatment. In these patients, we can determine if it's a pelvic congestion syndrome, or it has to do with varicose veins in the extremities. And we can study patients with a Doppler ultrasound, another angiographical study if it's needed, and determine if we give the patient a lower extremity treatment, or also maybe consider if it's an obstructive pathology or a non-obstructive pathology that will require embolization for reflux. So depending on the presentation, for example, in here, the varices, are they on the pelvis or extra-pelvic? We can do a direct treatment on the pelvic veins and an indirect treatment on the varicose veins in the gonadal area. As for anatomy, we saw that there were different areas where we can find the pathology, if it's a cause located in the left renal vein, the gonadals, or the iliacs, or if it's something that has to do with the escape points and extra pelvic varicosities. So these are some of the escape points that we can have, and we can see some indirect pelvic leaks that will manifest distally, for example, in the vulva, in the inner thigh, or the posterior thigh. And depending on the clinical presentation, we can find these escape points to treat them directly. The pudendal point is the most frequent, and we can see the location related to thigh and genitals. The eye point is the inguinal point, and this has to do with the inguinal ring and the round ligament. So we can find varicose veins in the inguinal canal, in the groin, or the genital area. And the G point has to do with the gluteal, the inferior and the superior. So we will find varicosities on the posterior thigh and the buttocks. As for the O point, this is the obturatory point, and we might find varicose veins in the medial thigh. As for the etiology and the physiopathology of the pathology, this has to do with an obstructive process, either thrombotic or non-thrombotic for the etiology, or congenital, and a reflux pathology. So this is mostly why this classification is useful. It helps us understand the causes of the disease, and it will help us organize ourselves into treating the real cause for a better result. It's very important that we consider this disease because it's very ignored, and it will change the quality of life of our patients. We will think of it as an iceberg, where we can see the point of the iceberg, but we don't suspect usually what's behind it. So it's something that really warrants our clinical attention. Thank you.
So thank you so much for that beautiful talk. I do have one question for you. So obviously this condition overlaps quite a bit with other conditions and potentially other symptoms from gastrointestinal and gynecologic and urological and even musculoskeletal sometimes. So what can we, or how can providers what should they look for in terms of signs and symptoms or red flags to think about these earlier so that we can help patients get to the diagnosis sooner before their lifestyle is so affected or impaired?
It's something that's frequent in multiparous patients. So sometimes this is frequent in more, like, for example, in Mexico than in first world countries because of the prevalence of multiparity. But also it has to do with symptoms that relate to, as I mentioned, postcoital pain, urinary symptoms. So sometimes these are patients that have been going to the gynecologist for different studies, and they haven't found really a cause. And they have to think about this possibility and maybe work with the gynecologist to have them refer the patients, because sometimes they are patients that are floating between two specialties and they don't really get treatment. And I think this is something that we have to educate maybe the population and also the other specialties around us, and even be aware ourselves that the patient could have symptoms related to pelvic disease. They might have lower pelvic pain, and consider this as one of the possibilities.
Vanessa, I have another question. If you say that the symptoms that they appear is only in the 10% of the population that has pelvic varicose veins, so what do you think about when we have to study these patients? Because it's only 10% they have symptoms. The problem is that we have a lot of patients with varicose veins, but not all of them we study in reality. What do you think about it?
For us, most of the patients come with their atypical varicose veins. So this is something that we can see in the consult. We can watch for these varicose veins in the buttocks or in the gonadal, in the genital area, and we can suspect there might be something else. So then maybe we can direct our interrogatory, our directed questions to them if they have any specific symptoms, such as we mentioned, that could indicate that there could be another problem. And if the patient comments as to they might be having something like this, then I continue to study them and see if they might have a benefit from an invasive treatment. But I think this is the way they get to our consult. So some of these are not referred. Actually, most of the patients that we see usually come to the consult, and it's a finding that when we see these atypical veins. So I think we have to be alert that there could be something else, but we have to direct the interrogation as to if it's worthwhile to continue the study of the pathology.
I completely agree with you. We have to check the patient, we have to ask. And some of them, like they're, for example, that we live in Mexico, most of the people, they don't speak about it. If they have dyspareunia, if they have some sex problems during, the sexual intercourse, they don't talk about it. So what do you think about having some, agreement with gynecologist, or talk about this in the, in the gynecologist, I don't know, maybe meetings, or maybe in your local area, have talks with us?
I think this could be very useful. However, sometimes I don't know if this gets in the middle of what they offer them for treatment, for example, hysterectomy, to continue, like, to have them stop their symptoms. But so I don't know how well they might take it. Or sometimes I have even talked with a gynecologist about this, and they don't believe in the therapy. So it would be useful to have, like, their own patients tell them the changes in the symptoms after the procedures. But yes, I think gynecologists are the main group which we have to convince that this is a treatment that will help their patients also.
But even I think that, I mean, a lot of times these patients before, or at least here in the US, where patients tend to see their what we call the primary care physician or their family doctor first. I don't know if that's, for example, how it works in Mexico, or if patients can just directly come to a gynecologist if they're having, pelvic pain. But if like patients are afraid to talk about it, I think the worst part is physicians not asking the questions, right? Because a lot of times, like patients don't even know, right, that something may be related to A or B, especially if their presentation is atypical. So I think it goes even before they get to the specialist, just having physicians really ask the questions. And there's such a gap in education and understanding that people are not even asking these questions. The people who should be asking these questions are not asking the questions. So, but I see what you mean as far as some gynecologists being reluctant just because it's, you don't talk about the things you don't do. And obviously you want to keep the patient. So if you're gonna send them out for something else, I mean, that may be a bias towards what you explain or not. So. But we could keep talking about this for hours, but for the sake of time, I would like to introduce our next speaker, Dr. Gloria Salazar. She's an incredible radiologist. She's an associate professor of radiology from the University of North Carolina, and she's a dear friend to all of us. So welcome, Gloria. Thank you so much for spending part of your morning with us, and take it away.
Thank you so much for the invitation of VLU, Lina, Rebecca. It is very hard to find a group of people that are amazing, intelligent, and friends. And I am very honored to be alongside with all of you. You know that we work together inside of the academia and outside, and I think that makes advances for the patient care. And I'd like to believe that we help more the patients because of this community that we create. So I'm going to go ahead and just briefly talk about how do I diagnose it and evaluate the patients. This is a mathematician that actually has a YouTube video for kids to love math. Now, I always love math because I'm a nerd, but some kids don't. But I thought this was very interesting because he says that you can only change perspective when you understand a problem from the inside, not only from the outside. And that's exactly what happens with pelvic venous disease or pelvic congestion. We know that pelvic pain, it's a very common issue in women's health, but we do not understand it from the inside. And so the view from the inside will give you a start point for you to evaluate this patient. So Dr. Rubio did an amazing job in introducing this topic and the issues with a diagnosis and widespread of adoption of this. So what we do know is that there's different anatomical points that this can lead to issues. But the major question is, what are the symptoms? And I think that when we start the evaluation, we need to be open-minded and understand that pelvic pain is not the only symptom. Pelvic pain is a start point. Depending on the anatomical location of the abnormality, whether it's renal, ovarian, iliac, or scape points, you will have different symptoms. And you may have all of this together in one patient, which makes it more challenging. So as we know, the reflux can cause the pelvic pain, postural, dyspareunia, and postcoital pain. Renal vein stenosis can cause symptoms in the kidney, flank pain, hematuria. Iliac veins can also be associated with leg symptoms, and the scape points can be localized to the pelvic, to the perineal area, vulvar area, but it can also be associated with pelvic pain. So what do we need to do is we need to appropriately select the patients to the right interventions. And that is challenging because of everything that was already presented. And if you don't ask the question, you're not going to have the appropriate diagnosis that was mentioned before. So the most important thing is understanding what lesion is causing what, and what are the symptoms that are more important for the patients, because then you can prioritize the treatment. So this is sort of my roadmap for the evaluation. You do have to have a multidisciplinary approach. We talk about collaboration. The best way to do that, go and present to your gynecologist, work together. They also want to make the best solution for their patients. So they want to hear from us, primary care physicians and physical therapists. We want to rule out other conditions. Dr. Rubio already mentioned that masses, the tumors can cause some pelvic pain. But most importantly, we want to confirm that the pain is venous origin. And how do we do that? We talk about this. This pain has to be postural, worse at the end of the day. postcoital pain is very indicative of pelvic pain of venous origin. And in the physical exam, you may encounter a rebound tenderness at the ovarian point levels, either on the right or on the left. Not necessarily need to be present. Some patients don't have that. And it's important to understand the age and onset. It is true that postmenopausal women rarely present to the clinic, but unfortunately, menopause does not treat anything. The varices are still there and you can still have issues. This is my chart of how do I evaluate the patient. So the multiparous classical presentation typically will have reflux and typically will benefit from embolization. And of course, you have to rule out all the other sorts of things. For example, leg symptom or extra-pelvic symptoms. In compression syndromes, in my experience, they can be very young, nulliparous, or more advanced age, not old, because we're never old, right? So not postmenopausal women, for example, can fall into this category. And then you have to look for compression. So my diagnostic workup usually tends to be CT. And the escape points, ultrasound is really good. And I know Dr. Jaworucka is very good at it and she can talk about it. And she published and she is the best, I think, as far as I know, in finding those escape points. So what imaging do we choose first? Well, each imaging has pros and cons. Ultrasound is great, but it's operator dependent. I don't think I can replicate the technique of Alex, but certainly it's a great technique for evaluating physiologic response and how the anatomy looks like. CT is also great. It gives you cross-sectional imaging, MRV as well, but there are limitations, not always accessible, and patients need to be well hydrated. Unfortunately, we can only see about 50% of patients, the iliac veins and compression points with ultrasound because of obesity and overlying gas. But for the most part, you can actually be a first study. Before even the Doppler, you know that those patients are going to have transvaginal ultrasound. Here's an example of a very dilated periarcuate vein. And what we consider to be significant or clinically significant is a pelvic varus more than 5 millimeter diameter in the uterine body. And this gives you a specificity of 91%. There is a specific protocol developed by Lapropoulos and now even further refined by the Brazilian group, the pelvic group, with Joanna Storino. So this is what we look for, the compression points as well as the reflux. And these are the definitions of clinically or significant stenosis or reflux. And recent data or more recent data shows that what is the real diameter that can cause pain? Well, we don't have a direct correlation of pain severity and pelvic venous disease, but we do know that competent ovarian veins measure up to 4 millimeters in diameter. Anything more than 8, I think you can suspect pelvic venous disease. And here's a CT. I usually now order CTVs, are easy to do. You just need to make sure that the patients are well hydrated and also that the phase of the study is done in the venous phase. What about MR? It's very expensive and not always available. I stopped ordering this mainly for the increased rate of false positive, 40%. You can see here patients can have a false positive when they take it to the angio suit and you do an IVUS, there's no compression. So I stopped doing that. I don't do it anymore. I'd rather have a cross-sectional imaging and an ultrasound. So how does that look in clinical practice? So here's a 35-year-old lady who has 38, who has pelvic congestion for a long time. And she has 2 different lesions. She has reflux in both ovarians, as you can see here. And she also has compression. And by IVUS, you can evaluate the level of compression. I typically consider clinically significant compression when patients have more than 70% diameter reduction in IVUS when you're evaluating the stenotic portion. And finally, what are the signs and symptoms? I want to repeat this because this is the most important thing. If a patient does not have postcoital pain, acyclical pain, it has to be present throughout the month. It cannot only be present in menstrual period pain. These patients with postcoital pain, with dyspareunia, increased pain with standing, and if they have vulvar varicose veins and ovarian point tenderness, they may have a 70% sensitivity for a diagnosis of pelvic venous disease. And last but not the least, this is my algorithm. The checklist that I have, I want to make sure the patients have first venous origin chronic pelvic pain, and then second, rule out obstruction. When you rule out obstruction, you have to ask about the symptoms, renal and extra-pelvic symptoms, and you want to make sure this patient already underwent a trial of ovarian suppression and rule out all the other things. But really, I'm confusing more than helping here because these are all the symptoms and different presentations of pelvic venous disease. So I am very, very lucky to have an amazing community of amazing women. This is my colleague, Mona Ranade at Stanford University. She's a wonderful researcher, and she came up with a decision support tool that I would like you to check it out. Here it is, how you use it.
Gloria, we are not hearing the video.
Oh, okay. So what we do here, essentially, we just select the main symptom, and you also select sort of the postcoital pain, whether they have premenstrual worsening. Once you select that, you get into a hemodynamic assessment. Then you can write the diameter of the ovarian vein that you see in the CT scan or ultrasound. And then you can even put the duration of the reflux. So this is the second part in this decision support tool. Then when you do the evaluation with imaging, you can see whether there is pelvic collateralization or not, and whether there's nutcracker syndrome. And you can actually add the angle, aortomesenteric angle. And all of this information is going to be put together so that you can have a summary of what your patient has. When you press to the anatomy, you can also find and look for pelvic varicosities. So you can select that. You can select dilated arcuate veins. And you can also select uterine vein dilation and May-Turner anatomy. Typically for the May-Turner anatomy, I leave it as suspected. If it is suspected, you can also do IVUS. But if you to completely rule it out with an ultrasound, you can just say not seen. And this gives you a scoring system based on the literature and based on the anatomy, how confident you are of this diagnosis. I find this is a start point for us to use decision support tools in these patients because there's so many different anatomical presentations and symptom presentation. And not only that, this gives you sort of the treatment options and then gives you the evidence-based table with all the literature that was utilized to create this tool. And most importantly, we know this disease is not covered by insurance in many other countries. So when you go all the way down in this evaluation or this decision support system, you can generate an appeal letter for insurance. And the letter will include all the different locations of the disease. So this is what I wanted to leave with. So this is the letter of the insurance. You can see here, you can send it to insurance, you can send it to the patient, save it, and then you move on with the treatment. So I just want to point out we're doing the Embolize trial to answer those questions about whether embolization does help pelvic pain and help spread this condition and this treatment to all women. And last but not the least, I think less is more. So evaluate all the anatomy, all the symptoms, and determine if the patient has venous origin chronic pain. Thank you so much.
Gloria, that was absolutely incredible. Like I never cease to learn from you, but that was, you put it all so clearly. I think we're, like you and I are lucky being here in the States, and lucky, quote unquote, because obviously here some insurance companies still cover it, but I don't do this anymore, but I remember the struggle of having to fight insurance companies. I can only begin to imagine what women around the world are dealing with, where there's just no coverage for any of this, and it is completely like it's impossible for anyone to afford this kind of treatment. So let alone the part of the diagnosis. I mean, all of this imaging, IVUS is not even available in most places. So clinicians are relying on God knows what kind of ultrasound potentially, and maybe CT, maybe MR. So this is absolutely incredible, and I love this tool. So is this free and available for everyone?
It is free and available. Yeah, I will share at the end.
Word, yeah, because I was not aware of this tool. This is incredible.
Yeah, no, we are working to refine this tool, and particularly with the Embolize trial, we're going to have data to support coverage all around the world. So I'm very proud of this study. We're not going to answer all those questions, but we're going to answer part of the question, and it's going to be a start point for other research projects. Hopefully within this group, we can come up with other things. But I will share this tool. This tool is being developed. I love the feedback from you all, and we would like to make it available. For me, the most important thing is that everybody knows about this. And just like Dr. Rubio mentioned, we need to have this as the forefront of diagnosis for all women in the world.
Right. What would you say, like from your experience, from the diagnosis standpoint and being a radiologist, I mean, again, going back, this is a global community. People are going to watch this webinar, from all places in the world. What would be like some quick tips for those that obviously don't have IVUS or have very limited access to diagnostic modalities? What are your tips?
I would say transvaginal ultrasound. If you have a transvaginal ultrasound that I showed you with dilated periuterine varices more than 5 millimeter around the uterus, or even myometrial dilatation of veins, and patients have venous origin chronic pelvic pain, that's a start point. You do a diagnostic venography, you will see more or less whether there's stenosis or not in the renal. But it's important to rule out the symptoms. If patients have hematuria, you already start from a different perspective. If patients have leg pain on the left side, May-Turner symptoms, then you have to change your algorithm. But I think a transvaginal ultrasound showing varices plus the symptoms, that's, I would say, 70% of your patients right there. And the rest you can do with venography.
And one last question for you, for those doing maybe, we have vascular surgeons who are doing, their own ultrasounds or have access to transabdominal more in the vascular world. What do you think about the position of the patient? Does that make a difference if they're standing versus they're laying down? What are your thoughts on that?
Definitely makes a difference. We are seeing already a difference in evaluation with ultrasound and CT on the diameter of the ovarian vein. So it is very operator dependent. It's very dependent on which time in the day the patient is having this done. Like in the morning, I think it's not helpful. We are collecting the data anyway, sometimes before the treatment, but I think that it has to be a hydrated patient. Position is very important. Valsalva is very important. But most important is the skill of the ultrasonographer, whether it's a physician or a technologist. And this is what I think is a disadvantage on our country, on this country, United States, because I know that in other countries, the physicians take that in their arms, like they just do it themselves, and it's more correlated with clinical symptoms, in my opinion.
Gloria, I think you take up in a point of your talk that it's so important, that it's quality of life. I guess that must be the goal of these diseases, the quality of life, the women, because if you know the patient, and when you are getting close to the patient, because sometimes these kind of patients are, when you treat them, they thank you so much, the treatment to you. So I guess that must be the point of view of all women, the quality of life, I guess. I don't know.
Well, I think that the problem with women's health, it's been neglected for also many years. So nobody listens to women. And I say this from own experience and from my patient experience. And this is why it's important to have this group of people that are interested, and it can facilitate for others to evaluate. The women are working so hard these days. Like, this is 2026. There are a lot of single mothers. There are a lot of women that have to pay the bills. They don't have any help. And these women walk around with pelvic pain 10 out of 10, and they still do their job. And so they're miserable. Now, I know this is luckily not a cancer condition, but it is a very bad disease to have. And you just get drained. And honestly, some of those women give up. Some of them go into disability. And we don't have this data, but we know that a lot of women go in disability because of debilitating pain here in the United States. So it is a real thing. Women just suffer so much in silence, and we need to change that. This is why we're here, and I'm very glad to have this educational opportunities to share with everyone.
Thank you so much, Gloria. And we are going to continue this incredible talks with the one who is going to tell us how to treat them. So I want to present Aleksandra Jaworucka. She is a gynecologist and vascular surgeon from Poland. She's a very good friend of us. And she's going to talk about it. How can we help these kind of patients? So for me, she's the best one to see the escape points. So thank you, Aleksandra. And I give you the talk.
Thank you very much, everyone, for your kind invitation. It's really a pleasure to be with so wonderful, powerful women who are talking about the pelvic venous disorders. I really appreciate your invitation, and I'm happy to be with you. You are my very close friends, and I am happy to see you at least online. So I will share my presentation. I hope you can see me. I will talk about the pelvic venous disorders, the treatment strategy, and outcomes. I have nothing to disclose regarding this talk. Whenever we want to start the treatment, whatever disease we have, very important is to treat symptoms, not images, especially when we are talking about the varicose veins located in pelvis. We have to remember that many patients with the varicose veins located in pelvis, they do not have symptoms. So finding varicose veins in that area doesn't mean that you have to treat such patients. We have to treat symptoms, not images. I will follow the treatment pathways and the treatment strategy based on the SVP classification. So I will start from the patients who are the most common group of patients. So the patients where the symptoms are located in pelvis, so S2. And then the varicose veins are located in pelvis. And the pathophysiology is reflux in the left ovarian vein, right ovarian vein, or internal iliac vein. And we know that based on the studies, the best way to treat such patients is pelvic vein embolization, which was also mentioned by Gloria and Vanessa. What can we do? What can we use to treat such patients? We can use coils, plug, gel foams, or liquids. The study has shown that there is no significant difference in the outcomes, but definitely less favorable results was for glue-based embolization. I usually use coil embolization and sclerotherapy. For the here is left and right ovarian vein embolization, I usually go through the left ovarian vein. Very often I use the crossover technique and go to the right ovarian vein, do the coil, then sclerotherapy, then go to the left side, do sclerotherapy, and then coil. And generally, it has usually good results. Based on the systematic review, you can see that almost 75% of patients had a pain relief. The other systematic review has shown that 70 to 100% had a pain relief. And the other study also similar results. So 70 to 100 patients had a resolution of the symptoms. Let's go to the next group. So the pain is located in pelvis. Varicose veins are located in pelvis, but pathophysiology is common iliac vein, left common iliac vein obstruction. It's non-thrombotic, so it's a well-known May-Turner syndrome. In that case, it's obvious that we should perform a stenting. Of course, it has to be a proven hemodynamically relevant iliac vein stenosis, as you can see here on the venogram, confirmed with the IVUS. And then after, with the IVUS and venography, we control the proximal landing zone to put a proper stent. We use the dedicated venous stent, and then with that, we control with IVUS and the venography. And generally, the results of such approach are really good. The problem appears when we have symptoms located in the second zone, so in pelvis, varicose veins in pelvis, and we have both reflux and obstruction. So what should we do in such patients? There are few options. You can start from embolization, you can do stenting first, or you can do both procedures. I will show you the literature. This is a publication by the Russian group Bar Gavrilov, and he presented, it was published in 2020, and here you can see the results that he performed stenting only, and the symptoms resolution was found in only 16% of patients. 83% of patients required further embolization. But the same group of people published 5 years later totally different results. They found that the additional embolization was found in only 30% of patients. So the same group, totally different results. Another study by Peter Papas, he found that stenting made the symptoms resolution in 76% of patients. And another study by the same group, they did stenting alone, and they found that no patient required embolization after such treatment. But you can see that the pelvic reservoir were present in 83% of patients, even though they performed stenting. And the reintervention was required in 13% of patients. What is really interesting for me, that they didn't do embolization in such cases, but they do additional stenting for additional compression, which they found distally. And there is also one interesting study. It's a systematic review. Here you can see that that isolated iliac vein stenting helped in 16 to 80% of patients, so huge range of patients. And additional gonadal vein embolization after stenting was required in 20 to 84% of patients. So generally, we still do not know what procedure should be done first, and still more studies are needed to give definitive conclusions. Let's go to another group of patients based on the SVP classification. So the pain is located in the zone 2, so in pelvis. We have varicose veins in the renal area and also in pelvis. So we have left renal vein obstruction, non-thrombotic, and left ovarian vein reflux. But the patient has only chronic pelvic pain, no flank pain, no hematuria, no proteinuria. And based on the study, in such cases, we should perform ovarian vein embolization. Of course, if we have flank pain and hematuria, so there an SVP classification is S1, so the pain symptoms are located in the first zone, varicose veins in the first zone, and there is reflux there is obstruction of the nutcracker syndrome. Of course, in that case, we can go for the treatment of the left renal vein compression. We can go for conservative treatment, we can go for surgery, or some people perform endovascular procedures. Let's go to another group of patients. So the patients with the extra-pelvic varicose veins of pelvic origin. You have to remember that because of the reflux is transmitted through the pelvic escape points located in the pelvic floor, most of these patients do not have pelvic symptoms. Studies has shown that more than 90% of patients with the varicose veins like this do not have pelvic symptoms. Of course, the symptoms can be located in the vulvar area or around the vagina. That's why it's very important how you ask the patient, so where the symptoms are located. Patients very often do not know if it's pelvis or not the pelvis. You have to ask the patient if it's a vulvar area or it's really deep in the pelvis. So I will show you what should we do in case of situation most common. So we have only symptoms located in the vulvar area or in the legs because of the varicose veins coming from pelvis. So the varicose veins are located in pelvis because it's a pelvic origin, and they are located in the lower zone, so zone 3A, zone 3B, or both zones. And never mind whatever pathophysiology it is, if it's reflux or obstruction, in that case, based on the studies, we should perform the bottom-up approach. So the local procedures, so we can perform sclerotherapy of pelvic escape points or surgical ligation. It is also recommended by the ESVS guidelines, so the European guidelines. Here you can find that the local procedures for the varicose veins and related pelvic escape points should be considered as initial therapeutic approach. Why? Because most of these patients do not have pelvic symptoms, so we are treating symptoms, not images, and the results of the bottom-up treatment are really good. I generally like sclerotherapy for such varicose veins because the pelvic escape points penetrate deep into the pelvic floor. They have a narrow course, and they are usually narrow and have a winding course. Here is what is my approach in such case. You can see I perform the sclerotherapy of intermediate labial pelvic escape points. I usually put the ultrasonography in leg, and I am standing where the head of the patient is. I usually use longer needle to close directly the pelvic escape points, and nurse is giving the foam. I usually use 3% STS for the veins lying below the fascia, the perineal fascia. You follow the foam migration, and generally the results of such treatment are really good. Here is my approach to the clitoral pelvic escape points. You can see the clitoris, so additional puncture, the approach as you can see here, and the foam migration. You also have to follow where the foam is going, and if the 5 ml is not enough, I'd use additional. Here you can see that the foam is going also to this external pudendal vein, which is very often connected with this pelvic escape points and cause varicosities on leg. Here you can see the inguinal pelvic escape points, which looks like a spongy tissue. It's a vein of the round ligament, and it's also very often connected with the external pudendal vein and cause varicose veins on the labia majora and on legs. And here you can see the foam migration to this pelvic escape points to close this pelvic escape point. I often got the question, do we really need to close this pelvic escape point? Or can we also only close the varicose veins? Look how huge these veins there can be, and they really can cause the pain in that area. So leaving these veins and closing only varicose veins superficially located definitely will not help the patient. Also here, you can see these are intermediate labial pelvic escape points. You can see how big these veins can be refluxing. You can see, I will just show you in a second, how can we easily find if there is a reflux in such veins. So the veins are around 7 millimeters, and leaving such pelvic escape points definitely will cause fast recurrency. That's why I decide to perform the sclerotherapy directly to the pelvic escape points. This is a needle and the set which I use. Here you can see on the first film, I will show you that I closed only the varicose veins lying superficially. Here you can see my puncture. The foam goes to the varicose veins, but it doesn't go to the pelvic escape points. And the second film, I puncture a little bit deeper to the pelvic escape points, and you can see how nicely we can fill this pelvic escape point with foam. That's why, in my opinion, closing directly the pelvic escape points gives the best results. In case of such varicose veins, I usually use the baby belly band to close all these pelvic escape points and compress the varicose veins to lower the pain after the treatment. It's a baby belly band you can buy on Amazon or directly by the page. And the results of such treatment are really good. Here you can see the photo before and after the treatment, and I have a 3-year observation of almost 300 of patients, and you can see that the occlusion rate 2 years after the treatment was 94%, so very good results. 3 years after the treatment, 90% of full occlusion of pelvic escape points. The patients were usually satisfied with the treatment, and 98% of patients would like to have this procedure again, although sometimes it may be a little bit painful. And the adverse events were not that big. You have to tell the patient that sometimes it may cause pain for up to 4 days after the treatment. No hyperpigmentation in this area. Generally, almost no superficial thrombophlebitis. I had one skin necrosis and because of additional angiokeratoma of Fordyce, and no DVT after such procedure. Why shouldn't we perform top-down treatment? Based on the guidelines, as initial treatment, it shouldn't be performed because study has shown that 80 to 90% of patients after embolization required further intervention for extra-pelvic varicose veins. Here is the photo of my patient. I treated it because of the pelvic pain. You can see that she has a lot of coils. I treated ovarian veins, both. I treated the tributary of internal iliac veins. In that time when I did it, we put coils and sclerotherapy. Now we know that we usually do only sclerotherapy. But even though we treated these varicose veins located in pelvis, the pelvic escape points did not close. As you can see here, I did the venography through the pelvic escape points, and you can see that they are open and they go to the region which was theoretically treated from the top-down approach, which didn't help. And study has also shown that up to 54% of patients had the recurrence of varicose veins at 3-year follow-up, even though they had performed pelvic vein embolization. So it also do not prevent the recurrence in that area. Of course, when we have a patient who has additionally pelvic symptoms, so S2, and symptoms located in pelvis, and the varicose veins are located in the bone, both zones, for pelvic symptoms, we perform embolization. But usually for extra pelvic sign and symptoms, we had to perform additional treatment from below. So this is my treatment protocol. Whenever I don't have a pelvic symptoms required treatment, I perform the bottom-up approach. When I have a patient with pelvic symptoms required treatment, I perform the pelvic vein treatment, embolization, or stenting, depending on the pathophysiology. Of course, when the bottom-up treatment does not help, you can always perform pelvic vein embolization as a second treatment. And in conclusion, more and more patients are coming to phlebological offices with such varicose veins. Most of them do not have pelvic symptoms. The diagnostic and treatment approach depends on patient symptoms. whenever you have a patient with the varicose veins coming from pelvis, the proper diagnostic and evaluation of the pelvic escape point is recommended before the treatment, and it gives you a good results after the treatment. Even in case of such huge varicose veins, we can really achieve good results. Generally, this approach is simple, can be performed in an outpatient basis. The radiation exposure and contrast injection of the contrast agent are avoided. It can be easily repeated if required, and definitely is cost effective in comparison to pelvic vein embolization. So my conclusion is to go for bottom-up approach in case of varicose veins coming from pelvis. And if you would like to read more, we published two publications on that. So it may help you in your further practice. Thank you very much.
Thank you, Alex. You are absolutely amazing. I think I've watched you or seen you give this talk many times, and I definitely, this is how I do things. Like I said, I don't do stenting anymore. I don't do embolizations anymore. But for those patients that definitely just need sclerotherapy of vulvar varicosities, that is exactly my approach, and I learned that from you. So thank you so much always for your amazing talk. How do you follow up these patients? Like, what's your protocol as far as seeing them back in clinic? How do you do ultrasounds, or are you just monitoring them clinically? Tell us about your approach.
So when I perform the procedure, I usually see the patients a month after the procedure, and I always do duplex ultrasonography for the pelvic area.
At that 1 month follow-up?
After 1 month, usually 4 to 6 weeks after the procedure. And I do transperineal duplex ultrasonography to check the pelvic escape points, if they are closed or not. If they are not closed, I perform additional sclerotherapy, or if the patient has additional varicose veins on the vulvar area which are not closed, or varicose veins on legs, I perform the proper treatment for these varicose veins. And then I see the patients again a month after the procedure. If the patient is fully occluded and I have a good results, I see the patients 3 months after the procedure, 6 months after the procedure, and then every year, just to see if everything is okay. I always tell the patient that they have to remember that the varicose veins in pelvis are still there, so they need to come for the follow-up to be sure that they will not have a recurrence. I think it's also very important, also for us, for our education, if the treatment was good and the follow-up is okay.
Aleksandra,
go ahead, Rebecca.
Sorry, we have a question for the chat. Well, first of all, Juan Esteban Paulini, he said that the problem sometimes is that we have a lack of the knowledge of the radiologist and the medical editor. So we agree of that. We need more talks, and we need more of this kind of webinars when we have a light from the experts. And the second one is for Aleksandra. Do you? I'm sorry, but the doctor, I cannot say the name because I cannot understand it. But he said that if you sclerose all the escape points at one session.
Do I perform sclerotherapy of pelvic escape points during one session? Everything depends on the volume. Yes, everything depends on the volume of the sclerosant. I generally try to do as much as I can because the treatment is a little bit painful. Of course, I put an anesthetic ointment 45 minutes before the procedure to reduce the pain. But generally, my aim is to close as much as I can during one session. And I usually inject, start from 5 ml to 1 pelvic escape points, and I check if it's enough. If it's not enough, I inject additional 2, 3, 4, 5, depending on how many veins are located there. That's why when you want to do such procedure, it's very good is to connect the needle with the strain. So the needle shouldn't be connected with the syringe, because if you decide that it's the amount of volume is not enough, it is very difficult to disconnect the syringe, because you will move the needle from the pelvic escape points. That's why I think this MacGyver technique, it's a very good technique. So I generally give a lot of flow. That is the truth. I give up to 40 ml per one procedure. So this is I try to close all pelvic escape points during one session. Of course, very often it's not possible, because if the patients had bilateral varicose veins and pelvic escape points, very often you can see that the foam migrate from one side to another side, and you think it's enough, but generally the foam is diluted, and if the patient comes after a month, and you can see that the pelvic escape points on the other side are not occluded, so I perform the sclerotherapy again a month after the procedure.
Thank you, Aleksandra. And besides that, I want to ask you if you have tried, besides the anesthetic, the ointment that you put, if you put some cold.
Do I put cold?
Have you tried to put some, I don't know, maybe
no,
like...
I put only anesthetic ointments, and then I put foil on that, and the patient is waiting 45 minutes with the foil. And then after the procedure, I put dry ice for like 30 minutes because of course of the risk of the swelling, and then it's a little bit irritated, especially I'm just now comparing the sensation when I use STS and when I use polidocanol, and I must tell you that with the STS the pain and the burning sensation is significantly lower than using polidocanol. So if you have the polidocanol, you have to tell the patient that just after injecting the foam, it can a little bit be burn, especially when you do it near the clitoris. So I put an ointment to reduce the symptoms of burning and such sensation.
Do you use the Varixio? Have you used Varixio?
Yes, of course. I think in that case, especially when you do that much foam, it's very important to use Varixio, because you have to be sure that you are giving the stable foam and not the huge bubbles, because with that amount of foam, of course, you can cause a harm to the patient. But with Varixio, the results are very good. I generally do not have any complications like related with the amount of foam which I give.
We have another question, quick question. Do you have follow a specific mapping chart when you evaluate your patients? Do you have a protocol for medical treatment? This is a question for Carlo Angelo from Mexico, a trainee from Mexico.
What was the question once more? Do I have a protocol of?
Yes, if you have a protocol for medical treatment, if you give
medical
some
treatment, yes. For medical treatment, I usually, after the procedure, give the ointment with ketoprofen, just to reduce the
inflammation.
Yeah, inflammation, yes, exactly. We also use sulodexide, especially when I do the leg. The sulodexide has also run the two randomized controlled trials that shows that it reduced the hyperpigmentation rate, and also it reduced the inflammation. So especially when you give a lot of foam, you have to think about that you increase the inflammation because of the sclerosant which you are using. So I generally use sulodexide after the procedure and ointment with ketoprofen after the procedure also. And I see the patients a month after.
Thank you so much.
And when you treat the patient a month after, you have to tell the patient also, when you treat the varicose veins in that area, that they can feel the vein after the procedure. So that it will be like an induration of the vein. It's not the thrombophlebitis, but they can feel it. They can palpable that. And very often they can feel the vein even up to 2 months after the procedure. And in that area, I do not do needle thrombectomy. I just wait. I just tell them to wait, and the results are very good.
I think it's just different when we think about sclerotherapy of lower extremity varicose veins versus pelvic veins. I mean, it's the same thing, but they're actually two totally different animals. I mean, when we do sclerotherapy of the legs, I mean, if we have a massive, a large vein, for example, there's so many things that we can do to compress that vein, not only to optimize our volume of foam so that we're not giving, like tens of cc's of foam, but it's going to increase our efficacy if we're able to compress it. So we can do things like leg elevation, we can do, cold, we can do even tumescent, like we can do tumescent anesthesia before, or tumescent just before doing sclero, but obviously this is not the case for pelvic veins. And so I think that, especially if we're treating massive veins like the ones you were showing, like a patient can easily take 20, 30, 40 cc's just to treat one side. And obviously we know that the effectiveness of the sclerotherapy is highly dependent on that sclerosant really touching the entire circumference of that vein, because if it doesn't, and if the sclerosant is diluted with blood, then we end up having some thrombosis, which then resolves, and we end up with an area that didn't get treated, an endothelium that wasn't damaged, and that's where recurrence comes from. So I think that having excellent quality foam is even more important in pelvic varicose veins than in lower extremity veins. And you know, obviously, if we try to do as much as we can in that session, that's ideal, but just being very judicious and understanding if there's going to be a lot, it's better to just space it out to make sure that what we're doing in that one session is going to be effective. Then we can always come back and do the wrist or the other side and do it in an optimal way as well.
Yeah.
I know that we could keep talking about this. We've already passed our 10, at least EST mark, but Vanessa had a case that she wanted to share with us. I think what we need to do is we need to have a follow-up of this webinar, because I need to continue. I think there's so much that we need to talk about, and there's so many questions where we could actually, I would love to just do cases with you guys, if you agree, Gloria and Vanessa and Alex, if you guys would be available maybe later this year, we can join again and just do cases. What do you guys think about that? But I think that'll be really helpful. But I want to thank everyone for spending a little bit of your morning with us. This was an incredible webinar. This was absolutely amazing, you know, all-star speakers. So I'm really, really grateful for you guys agreeing to participate and being with us and sharing all of your knowledge. Rebecca, thank you so much for, again, being my partner in crime and joining me in this adventure. And everyone who joined, thank you so, so much. Just as a reminder, this will be, this has been recorded and it will be available on the YouTube channel for everyone to review it, for your friends, your colleagues who couldn't attend. Make sure that you're sharing this and help us spread the word about Venous and Lymphatic University. We're all focused on learning and creating a global community. So thank you so, so much, everyone. We'll be sending out information about May's webinar.
Thank you so much,
you.
Lina.
Thank
It's so
you.
nice to be here, your partner, and thank you so much for all my friends.
Yeah.
Thank you.
Bye, everyone.
Thank you
Have a
very
great
much.
weekend. Bye.
Thank you.